Good evening, ladies and gentlemen. I am Dr. Neha Jain, and I welcome you all on behalf of Emcure Pharmaceuticals Limited to another wonderful evening of No Thrombosis workshop series. I am pleased to share with you all that we have successfully conducted 7 workshops of no thrombosis so far, and today is the 8th workshop of the series. This wouldn't have been possible without the mentorship and support of our faculty members and support of all our viewers. This No Thrombosis workshop is a small educational initiative by Emcure Pharmaceuticals to spread more awareness about stroke and its management. We are very honored and delighted to have the stalwarts of the country with us in this initiative. I would first like to introduce and welcome our course director, sir. Kindly give me a minute. My slides have got stuck. Yeah, just give me a minute. I first welcome our course director, Dr. UK Mishra, sir. Dr. Mishra, sir, is the director and HOD of Neurosciences Department at Apollo Medics Super Speciality Hospital, Lucknow. Sir founded the Department of Neurology at the prestigious Sanjay Gandhi PGI Institute in 1987. He was the head of the Department of Neurology at SGPGI Lucknow. Sir is the director, executive registrar, dean, and in charge of research at SGA PGI. Sir is trained in clinical neurophysiology in Italy, Sweden, and USA as a WHO fellow. Sir has made some excellent original contributions in the field of stroke, epilepsy, CNS infection, Guillain-Barré syndrome, neurotoxicology, and many others. And he has over 450 articles published in various reputed national and international journals. I now welcome our moderators for the program today. Our first moderator is Dr. Jayanta Roy, sir. Dr. Roy is the Director of Stroke Program and Senior Consultant of Department of Neurology at Institute of Neurosciences, Calcutta. Sir is the recipient of 2005 American Society of Neuroimaging William McKinney Award for the Best Manuscript Presentation based on clinical research in neurosonology. He is a certified neurosonologist accredited by American Society of Neuroimaging in 2005. He's made some scientific presentations in reputed international forums, including the prestigious European Stroke Organization Conference, World Stroke Congress, and various others. He's the member of the editorial board of Journal of Stroke Medicine, member of Global Executive Committee member of Society of Neurosonology India, and member of Educational Committee of Joint World Stroke Congress, Hyderabad of 2016. I now welcome our second moderator for the program today. Our second moderator is Dr. K. Ashokan, sir. Dr. Ashokan is the Chief Neurologist and Head of the Department Neurosciences at Sri Ramakrishna Hospital, Coimbatore. Sir is a life member of Indian Academy of Neurology and Neurological Society of India. He is also the active member of American Academy of Neurology, Movement Disorder Society of India. Sir is the president of Coimbatore Neurological Society, also the president of Tamil Nadu and Pondicherry Association of Neurologists. Sir has presented papers in various national and international conferences on stroke and epilepsy, and he has special interest in stroke therapy. I now take pleasure in welcoming and introducing our key speakers for the program today. Our first speaker is Dr. Arindam Ghosh. Dr. Arindam Ghosh is a consultant neurologist at Narayana Super Speciality Hospital, Havra, and Sri Aurobindo Seva Kendra, Kolkata. He is recipient of the prestigious Dr. Emcure Gold Medal Award for the best outgoing student in his DM time from Sri Ramachandra University, Chennai, and is also won the National Best Paper Award in API Con in 2002. He is a co-investigator in multiple drug trials on Parkinson's disease, partial onset epilepsy, and multiple sclerosis. He'll be presenting an interesting case of thrombolysis in a case of large vessel occlusion. I now welcome and introduce our second speaker for the day. Our second speaker is Dr. Varun Rehani. Dr. Varun is a consultant neurologist at BLK Max Super Speciality Hospital, New Delhi. He has special interest in the field of stroke, headache, multiple sclerosis, Parkinson's disease, and various other movement disorders. He was the senior registrar at Ram Manohar Lohia Hospital for a good 3 years, New Delhi, before joining BLK Max Super Speciality Hospital, New Delhi. He'll be presenting a very interesting case on stroke in a young soldier. With this brief introduction of all our key faculty members today, I would now request our course director, Dr. UK Mishra sir, to kindly give us the overview of the program. Sir, over to you.
Thank you very much. Am I audible?
Yes, sir.
So it's a great opportunity and a very nice opportunity to meet you all. And this format of presenting cases and discussing cases, I think it is one of the best. It is interesting, and the information sticks to the mind. And you know, we may collect whatever information is possible, but unless it sticks to the mind, it forms synapses in the brain and alters the behavior. It remains information and occupies only space in the mind. So I think the best method, I have been actually working on some information on how the COVID will affect our education system. And this is what it is. That, now we can't attend conferences, we can't have direct communication, so it's a distance learning. But in distance learning, again, the attention span is short, and when you get the information, soon the brain gets fatigued and the information doesn't change the behavior. Whereas when you have seen it directly, you have done it with your own hands, it forms synapses and the behavior is altered. So I think one of the major things which is going to change our behavior now in post-COVID era will be the distance learning programs. And in distance learning program, I think the case presentations, which have always been looked down in academic areas, will become more important. And this, I thought, this program will not run so long, 8 sessions, and 8 sessions and 2 cases, 16, sometime we presented more than 3-4 cases. So 20 cases have been presented, and people have been attending, listening, and appreciating. And I myself have learned such a great deal by listening to these cases, and these cases will remain in your mind. And sometime when you get a similar problem or identical problem or a similar problem, you will be better equipped to deal with them. So with this few words, I very much look forward to the interesting sessions, which will be the two neurologists will be presenting their cases, and we all will go richer. Thank you very much.
Thank you so much, sir. And your words of encouragement mean a lot to us, and they are the real reason behind the energy and enthusiasm. We come back every month, and trust me, for us at Emcure, for us, KT means you, Dr. Roy, and Dr. Ashokan. This program is synonymous, and it has to run under the guidance of all 3 of you. So thank you very much for being with us here today amidst these difficult times, finding time for this, KT. We are really thankful from the bottom of our heart. And let's start the program. I welcome Dr. Roy, sir. Sir, good evening once again. Sir, we can go ahead. Yes, sir.
Yeah, sure. So the first presenter will be Dr. Ghosh, I think.
Yes, sir. Yes, sir.
Arindam.
Yes,
please.
Thank you. Good evening. All right, let me try and share my screen. Is the screen visible?
Yes.
Okay. I go into the slideshow mode. Okay. At the outset, I thank the organizers, Emcure Pharmaceuticals, for giving me a chance to speak at this very august gathering of stalwarts in stroke medicine and colleagues. UK Mishra sir, I've had the privilege of listening to several times in conferences, and I really enjoyed listening to his electrophysiology classes, apart from many other lectures that I've heard. Dr. Ashokan and I have been meeting at the sidelines of various conferences in Chennai, where I did my DM. And it's always a pleasure and privilege to meet Jananda. He's the person who really revitalized stroke neurology in Kolkata and Eastern India. So he's the person who was a kind of pioneer in stroke medicine. We just, all of us are just following the pathways that he's shown us. So a very warm welcome to all 3 of you. Also, my co-speaker, Dr. Varun, I'm meeting him for the first time. So it's good to make his acquaintance as well. I'm trying to present two cases today. They're two short cases, and both of them are the application of thrombolytic agents in large vessel occlusion. And I'd like to start with the disclaimer. I'm only a general neurologist who's got an interest in stroke. I'm not a stroke neurologist per se, so do excuse my mistakes if there are any. I'll be very, very happy to learn from the three stalwarts that are present here this evening. So I'd like to begin with a question. In the era of mechanical thrombectomy, is there a scope for intravenous thrombolysis with whatever agent in patients with large vessel occlusion? Okay, so the first case is that of an elderly lady. She was 74 years of age. She presented to our ED. She was unresponsive at the time of presentation. And when my ED physicians assessed her, they noticed a gaze preference to the left, and her GCS was low. She was about 5/15. And of course, because of the low GCS, she was intubated. And the NIHS score that was calculated then was more than 20, as per the ED physician. So as you would expect, the stroke code was activated. The patient was subjected to a CT brain, an angiogram, and an MR screening, which looked at DWI and T2 flare. As you can see, the image on the left, you can see the IC is practically invisible. And there's a large left hemispheric stroke on a DWI scan on the right. So the patient, Mrs. G, 74 years old, lives very close to my hospital, and she had the onset of symptoms at about 10:30 in the morning. She presented rather quickly, perhaps because of the magnitude of symptoms. She was sitting and having a cup of tea with her family members, and she suddenly became unresponsive. They could rush her to the hospital. She reached us by about 11 in the morning, and by the time the imaging was complete, it was about 40 minutes past 11. And you could make out from the CT angiogram and also from the clinical symptoms that she's suffered a large vessel occlusion, in all likelihood an internal carotid artery stroke. So the question was, do we thrombolize her or do we take her up directly for MT? My friend and colleague, Dr. Kaushik Sundar, who's an interventional neurologist, was actually visiting our hospital at the time, so he was right there. So the question was very, very easy. Do we take her for MT or do we go for a thrombolysis? Unfortunately, we were kind of handicapped at the time because the cath lab was occupied with a couple of cardiological cases. So there was no way in which we could get the cath lab over the next half an hour. As the decision lay with me, I decided, okay, let's go for an IV thrombolysis. We have nothing to lose, really. We can always take her up for an MT once the thrombolysis is done. So I administered IV Tenectase at a dose of 0.2 milligram per kg body weight. And soon after the IVT, we took her up for mechanical thrombectomy to the cath lab. It was about 20 minutes or so after the administration of IVT. Now, this is, of course, from the images I took with Dr. Kaushik Sundar. This is he who's been doing the procedure. And as you can see, the first shoot itself, say about 20-25 minutes after the administration of the Tenectase, you see, we were expecting the IC to be occluded. The IC has recanalized, and it's now only an MCA occlusion. The IC has practically recanalized. So about 8 or 10 minutes later, Dr. Kaushik tries to introduce the guiding catheter. This is during the second shoot, the guiding catheter, because he now believes that this clot in the MCA, the occlusive clot, has to be retrieved mechanically with the catheter-guided procedure. So he's introduced a larger guiding catheter. And when he introduces the second shoot, say 8 or 10 minutes after this one, he realizes that the MCA has also been reperfused. So within about 28 to 30 minutes after the administration of Tenectase, in a lady who was 74, presented to us rather quickly, say about an hour or so, we had administered the Tenectase. The first shoot and the second shoot shows complete recanalization of not just the IC, but also the MCA. She did pretty well. 48 after stroke, she was extubated. She remains, of course, aphasic, but she made a very good motor recovery. And about 3 months of follow-up, her MRS score is just about 2. Okay, so 48 hours later, we did another CT at 24 hours, and then 48 hours later, we see there's absolutely no involvement of the subcortical structures. It's pretty much clear after 48 hours from the administration of Tenectase. The next patient is Mrs. M, who's 66 years old, and she's suddenly come to our hospital with speech difficulty. About an hour and a half from the onset of symptoms. She has no known comorbidities, not to the best of our knowledge. On examination, she was aphasic and had a gaze preference to the left. She had a right-sided hemiparesis. As you could expect, she would have a large, the gaze preference to the left. She has a score of NIHSS of more than 10, likely to be a large vessel stroke again. So the code was activated and she was shifted to the CT room. As you can see, the CT brain with angiogram. The angiogram shows the M1 to be occluded here. So the aspect score was about 10, but the CT angiogram revealed left M1 occlusion. She was shifted back to the ED when she was thrombolized with Tenectase at the dose of 0.2 milligram per kg body weight. And when she was taken to the cath lab, again, the introduction of the guiding catheter, during the first shoot itself, you see that the MCA has been practically reperfused. The spontaneous recanalization, say about 20 minutes or so after the administration of Tenectase. This patient did even better. At the end of 24 hours, she made a near complete recovery. She was discharged on day 4, and about 3 months of follow-up, but the MRS score is 0. That's actually the best outcome that you could have. It's an excellent outcome. So where do we stand with IV thrombolysis in patients with large vessel occlusion? That's the question we need to ask ourselves. The AHA-ASA guidelines are very clear. Any patient who's eligible for thrombolytic agents present to us within the first 4.5 hours should receive IV alteplase. It's class 1, and the level of evidence is very strong, class 1A. That means the benefit far outweighs the risk, and that's been based on multiple randomized controlled trials. Also, in patients with a hyperdense MCA sign, IV alteplase is beneficial. So this is 2A, of course, but this suggests that if you have a hyperdense MCA sign, the patient is presented to you within the window period, IV alteplase does not cause any statistically significant deleterious effect as compared to the conventional standard therapies of choice, which is antithrombotic agents. So IV alteplase at least does not cause any harm, likely to be beneficial. The European Stroke Organization's guidelines on this is that for any patient who presents to us within the first 4.5 hours, whether or not a large vessel occlusion should receive intravenous thrombolysis. Here, the quality of evidence is quite high. The strength of recommendation is, of course, very, very strong. We look at this particularly interesting trial, the study, which is a meta-analysis which looks at direct mechanical thrombectomy, or DMT, versus bridging therapy, where we've administered IV thrombolytic agents, followed by an MT. And this strangely finds, if you look at the 4 trials that have been looked at, the DVT, the direct MT, Mystic Clean, and SKIP trials, you will see that there's a marginal, at the end of, say, 90 days, the modified ranking score of 0 to 2. The clinical outcome for patients who've been administered bridging thrombolysis, followed by MT, is slightly or marginally better than that of those who've received a direct MT. But it's statistically not very significant. But in other words, bridging MT is at least not inferior. Perhaps the perfusion is a little better with bridging MT rather than with direct MT. But the more interesting point is, note that for all of these trials, all of these centers were MT capable. But if you look at the time that was taken between randomization, which is coming to the ED and being assessed to be a patient of acute ischemic stroke within the first 4.5 hours, to groin puncture, with or without bridging thrombolysis or direct MT, is pretty much the same. So no matter whether you are administering thrombolysis before MT or if you're taking the patient after MT, if the time is more or less the same that's taken, you would rather go for an IV thrombolytic agent followed by a mechanical thrombectomy rather than going for mechanical thrombectomy alone. I by no means advocate delayed thrombectomy. I mean to say, without delaying thrombectomy, if the time span is the same, you might as well go for a thrombolytic agent before going for thrombectomy. Another trial, this is the SWIFT direct trial. This looks at the fact that direct mechanical thrombectomy failed to show non-inferiority. They were trying to see if it was non-inferior, but they failed to show non-inferiority when compared with bridging thrombolysis. That's IV TPA followed by thrombectomy for LVOs. And the reason, this is Jan Grala's estimate, that even though the ultimate functional outcome is very similar for both arms, there's no reason to skip thrombolysis because the post-intervention recanalization rate was much higher in the thrombolysis arm. So if at all, is likely to be of benefit with bridging thrombolysis rather than going for direct MT. Now, if we have a large vessel occlusion, what drug do we use? Do we use a tenecteplase or do we use an alteplase? Which is also a very, very important question, given many of the attributes of tenecteplase. It's got better fibrin activity. The ease of administration is so much better, so much easier to administer the drug, and the fact that This has got longer half-life than alteplase. So this is a drug which is to be considered for the future. So this is an interesting statement by the ESO, which says that any patient with acute ischemic stroke within the first 4.5 hours, even with large vessel occlusion, those are candidates for mechanical thrombectomy, and in whom intravenous thrombolysis is being considered, does IVT with tenecteplase lead to a better functional outcome than with alteplase? And we look at a meta-analysis of 3 trials. As I said, we do know that TNK has higher fibrin activity, better half-life, and of course has the ease of administration. It's a single bolus dose as compared to infusion with alteplase. The 3 trials that we looked at were TNKS2B, which had to be curtailed in between, ATTEST and the NOTEST trials. These trials meta-analysis suggested there was no statistically significant difference in the proportion of patients achieving either excellent or good functional outcome at the end of 3 months in either of the arms. There was also no significant difference in the incidence of spontaneous ICH. But the question was it a faulty study design? Because none of them looked at non-inferiority. They were trying to establish superiority of tenecteplase over alteplase, which did not really happen. But none of them really looked at non-inferiority. When you looked at the meta-analysis of 5 trials, including these 3, and the TAIS trial and the Extend-1A TNK trial, this is, of course, the tenecteplase versus alteplase in the acute ischemic stroke trial, and the Extend-1A TNK trial. If you looked at all 5 trials taken together, TNK is non-inferior to alteplase, A. More importantly, this finding was largely based on the findings of the last 2 trials, the TAIS and the Extend-1A trial, both of whom predominantly had their patients as large vessel occlusions. So perhaps tenecteplase is better than alteplase when it comes to large vessel occlusions. So look at the TAIS trial, where you looked at tenecteplase with 2 doses versus alteplase within 6 hours. You can look at all of the 3 were large vessel strokes, ACA, MCA, and PCA. The primary outcome, of course, was the percentage of perfusion lesion that was reperfused at 24 hours on MRI, and there was a change in NIHSS from baseline in the first 24 hours. TNK was superior to alteplase in both the primary outcomes, and the frequency of spontaneous ICH was much the same. And 3 months, also, the better functional outcome remained with the TNK arm as compared to the alteplase arm. We looked at the Extend-1A TNK trial. Again, this was a non-inferior trial. A dose of 0.25 versus 9 was used. Within first 4.5 hours, large vessel occlusion involving internal carotid, M1 and M2, and basilar arteries. Again, the primary outcome was reperfusion of more than 50% of the ischemic territory, or absence of retrievable thrombus on an angiographic evidence. 22% of patients with TNK had recanalization, whereas 10% had recanalization with alteplase. The p-value for non-inferiority was quite low, though you might say not statistically significant, but still quite low, better off than alteplase. And again, at 3 months, there wasn't a lot of difference, but as the SWIFT Direct trial also suggested, there was better reperfusion with TNK than with alteplase. I'll skip this slide for want of time. So the recommendation is, in acute ischemic stroke within the first 4.5 hours, if you're looking at large vessel occlusion, and this is a candidate for mechanical thrombectomy, if you're considering intravenous thrombolysis, you might just use tenecteplase at a dose of 0.25 milligram per kg over and above alteplase. Of course, the evidence is not really great, not strong, because it's based on 2 trials, but perhaps with time, tenecteplase may gain its position of importance over and above alteplase. This is one of the last studies that I wanted to quote. This is again from my friend, Dr. Kaushik Sundar, with his team, with Dr. Gigi in Kerala, in Rajagiri Hospital. They had looked at 120 patients who received thrombolytic agents within the first 4.5 hours. This was the 10-valve study, which compared tenecteplase versus alteplase. 55 patients were on tenecteplase with 65 on alteplase. A much larger proportion of patients had large vessel occlusion in the tenecteplase arm, about 33% compared to 19% on the alteplase arm. But recanalization rates were better, with about 17% with tenecteplase and about 8.3% with alteplase arm. Of course, this was not statistically significant, as you would expect, because of the smaller numbers. But even then, even in an Indian population, tenecteplase seems to have better recanalization rates in large vessel occlusion as compared to alteplase. The last slide on that, what is the WSO's position statement in the COVID era with both these drugs for acute ischemic stroke? And Jairaj Pandian is one of the important collaborators in this particular position statement. And The statement is that IVT must be administered to all eligible patients within the first 4.5 hours from the symptom onset. There's no doubt about that. This is not debatable. TNK has been championed in a few centers, mainly because of its ease of administration, because it requires a bolus dose. So in these pandemic times, and this is still going on, you might choose to call it an epidemic with Omicron or whatever you want to call it, endemic with Omicron, but still COVID is raging quite widely. Here, Tenectase may outscore alteplase because you eliminate the need of an hour-long infusion with alteplase. So my view is IVT is a definite must, even if MT is being planned. TNK is perhaps better because of recanalization rates being better, or at least comparable to alteplase, if nothing more, and therefore also because of the ease of administration. Remember also that even in those centers where MT-capable centers were looked at, bridging therapy perhaps had a slightly better outcome in terms of recanalization rates than those who went for direct MT. Thank you very much for giving me a patient hearing.
Thank you, Arindam. It was a great presentation, and you nicely drew the point home. It's very well taken. I think we do not have much doubt about promoting IVT before MT in most of our cases. I think almost all of us, we are convinced that I personally in favor of giving IVT before MT, though there are other school of thoughts. People believe that a direct MT is possible, and data shows that they have almost similar kind of outcome at the end of 3 months. But those who advocate IVT, especially your first case, when the patient reached hospital within the first hour, we should not leave that opportunity, because that is the time the IVT has got the best the best NNT for 60 minutes or 90 minutes. So we should not leave that opportunity go by. And so that's the right thing you did. So if I add a couple of points, especially when you combined the bridging therapy, the upside, of course, is that it opens up before you actually do the mechanical thrombectomy, as you've shown in your case, as it's shown in the trials, especially extend IA-TNK. And there is little bit preference to TNK over alteplase in opening the LVO. And there is another point is that people say that, and I also believe that when you open up the artery, either IVTPA alone or by a subsequent MT, when the clot is disintegrated and goes to a sum of the M3s, where you have a TPA on board, that take care of those small clots disintegrated downstream, where your mechanical cannot even reach and take them out. So that is an additional advantage. And if you talk about the downside, that is another thought, that especially patients who are going for a bridging therapy and patients needed a stent to be deployed either at the neck or the MCA because of stenosis. In some cases, though rare, but we have to leave the stent back after retrieval of the clot because of the in situ stenosis. But we might have to give them additional antiplatelets on the first 24 hours on the top of TPA, which is the chance of bleed or not. That is another school of thought. But if you look at the data of especially ESCAPE trial, there are around, if I recall, 12 cases. They had to do a neck angioplasty and stenting to make a room upstairs to dislodge the clot in ESCAPE trial. And none of them actually had a bad outcome. So if you look at that small number, even after that, the outcome is not
adverse,
changed or affected. So in a nutshell, in my opinion, as you concluded, IVTPA before mechanical is always helpful. It is easy, and it has more advantages than disadvantages. So Ashokan sir and Professor Mishra sir.
I am Dr. Ashokan. I think it's a very nice presentation, Dr. Ghosh. I'd like to tell you one thing. Of course, we do prefer Tenectase in a large vessel occlusion. The reason, number one, is, as you said, is administered very easily, and the time taken is only about 5 minutes. We just push it. Instead of waiting for the alteplase to go for 45 minutes. And the next thing, of course, all these LBOs, most of the cases, we do try with, if they come within the window period, IVT with especially Tenectase. And of course, later go for, if necessary, go for angio or straight to the angio suite and look for any remaining residual occlusion. If that is there, go for suction thrombectomy because it's easily suckable. After your IVT, it becomes easily suckable. Or stent retriever, remove the clot. And of course, as in your case, it has already opened up, of course, and clinical improving, we don't do anything. We just follow up the case with antiplatelets, double antiplatelet, as you know initially. That's one thing. And another thing, of course, like direct thrombectomy, at least in our center, direct thrombectomy, there are pros and cons for that. In our center, what we do, we suggest, we give both options to the patient if they are within the window period. You have to go for IVT, then later, if necessary, after angio, go for thrombectomy. And some of them, they may not be willing for 2 procedures in one sitting. No, you tell me only one procedure, we can afford only for that. If that is the situation, I'll go for direct thrombectomy because IVT and after angio, and if the clot is remaining, then you have to go for mechanical thrombectomy in such a situation. Otherwise, I think within the window period, ideal is that too, as in your first case, just hardly 120 minutes, that's all. Yes. You go for thrombolysis, then go for angio, and the remaining clot, go for thrombectomy. Already there is opening of the vessel, good revascularization, reperfusion, stop with that and follow it up. That's my take up. Yeah.
Thank you, sir.
But anyhow, you have done a beautiful job.
Thank you.
Sir, your opinion, sir? Sir, you are muted.
Yeah, sorry. So, very nice case, enjoyed it. And I was just thinking that if this patient was in some other, supposing your lab was free and the interventionist would have said, okay, why not do one procedure? Because he will feel, redundant if you have thrombolized him IV and then, he just keeps on doing an angio possibly, patient is improved, then what to do? So this problem is always faced and, people are always divided, not only by the academic information, but also by the structure of the hospital and priorities and who takes it first and who is more effective. So these are various questions. And I always believe that, if you have given IV thrombolysis, you gave it very early. And if the patient is improving, then let him improve. And then, you can do an angio, and if everything is fine, leave him. But, otherwise, you have to go for, direct thrombectomy, and that is a problem. Second advantage of Tenectase is not only the ease of administration, but also the cost. I mean, it costs you 1/3. So I think, for us, for me, low cost, convenience, I think, and almost similar efficacy, if not better, leaves me no doubt about the use of Tenectase. Still, in spite of these discussions, this patient, if he goes to some other centers, I'm not sure that everybody will give IV thrombolysis. Many people will go because it was almost a large total MCA, and people will have a point, why not? Why waste time? And, they may be hemorrhagic and, let us go for thrombectomy. So that is the thing. But I'm very, very happy to see the response. It was lucky. Maybe in the next patient, it may not be so good and we may have problems of, but, thank you very much because it is not the usual conventional total MC large vessel occlusion getting such good results. So thank you very much.
Thank you, sir.
Well, before we finish with, there is just one interesting thing I noted. Arindam, can you just go back to your slides where you did the post-thrombectomy CT scan of that lady, first lady?
Yes, I think I can go on back to that. Give me a second. Yes.
Right. Yes. Just make it a full screen.
Yeah.
Now, if you here, as you already mentioned, that the patient had a very good motor recovery.
Sorry, give me a second.
Yeah.
Yeah.
So if you look at the post-thrombolysis scan, the left hemisphere swollen and little hypodense. And had it been an infarct, the patient would have been paralyzed and completely aphasic.
Aphasic, yes.
So I think this could represent a reperfusion. So if you had a follow-up scan, you must have done after a few days. So that usually shrinks. So many patients were successful reperfusion, and the next day CT shows a bigger hypotense area with a relatively reserved patient. Sometimes represents this
Reperfusion
edema shrinks very fast. So this is probably representing that. That's a nice case. Thank you.
Thank you.
Okay, Dr. Neha.
Yes, sir. We go on to our second case. Dr. Varun.
Varun, we are not able to hear you. We can see your slides, but not able to hear you.
Muted by any chance?
No, sir, he's not muted. I think, Dr. Varun, you can use the laptop mic instead of what you call as if you are using earphone and something like that. You can.
Dr. Varun, can you hear us?
That's what I'm. Yeah, he can hear us.
You can hear us.
We cannot.
Can you disconnect your this thing?
Earphone and use the laptop mic and the.
I think he's using the buds. If you can just remove them and
remove the buds, disconnect the
just
Bluetooth and then.
Yeah. No, we cannot.
Needs rebooting.
Yeah, why don't you just join again? Can we just see if you're.
Can you please log out and join?
Yeah.
It sometimes happens.
No, we cannot hear you. Can you connect from two devices, like you join from your mobile as well as your laptop, and you present from your laptop, and then you can talk from your mobile?
Sir, can you try unmuting? There's a small arrow above the unmute button.
I think he has already
press the arrow and press same as systems. Same as system. There's a small arrow near the unmute button.
Near the mute button, there is a small arrow.
Select microphone, same as speaker.
Same as system. Huh?
Same as system, sorry.
Same as system.
Okay, it's not same.
नहीं हो रहा ना, तो maybe the other frugal thing. मैं WhatsApp करूँ क्या link आपको, Dr. Varun?
नहीं, he's joining. He's joining.
He's joining. Okay.
Yes.
Yeah. Then you can present from your.
Can you hear me?
Yeah. That's perfect. Then you can present from your system.
Yeah.
Usko mein, yeah. Yeah. You're making full screen, please.
Yeah, I'll make it full screen.
Yeah. Thank you.
So everybody can see the slide?
Yes.
And everybody can hear me? So good evening to all. I'm Dr. Varun. I've completed my residency from Army Hospital last year, and I've recently joined in BL Kapoor Max Hospital recently. And it's a great honor for me, and I would like to thank the Emcure Pharmaceuticals for providing me this opportunity. And I'll also give a sincere thanks to all the esteemed faculty that I am going to present to. And I have also a very good, want to say a very good thank you to Dr. Ghosh, who has given an exhaustive coverage. So he hasn't left anything for me to discuss other than my simple case. So I'll start with this. This was a case during my final year residency that I had seen at Army Hospital. So this was a 34-year-old male, a serving soldier, right-handed, who was posted at MH Merit without any known commodities and was a resident of Delhi and was during a vacation at Delhi, who presented with a sudden onset weakness at 11:30 hours on 21st February 2019, in which he had weakness of the left half of the body and deviation of the face towards the right side with difficulty in speaking. That very morning, he suffered a road traffic accident and had a superficial injury to the right side of the neck by a car door opening that had happened early in the morning at around 7 o'clock. After that, he was doing well and had just complaints of local neck pain over the right side of the neck that the trauma had occurred. So at around 11:30, he suddenly developed a weakness of the left side with deviation of the face and difficulty in speaking, and he was carried on a stretcher, and he was not able to move his left half of the body and reported in the emergency room at base hospital at 13:30 hours. So we as neurologists at Army Hospital sometimes have to give cover to the base hospital at there also, and I was on call at base hospital on those days, and I had received the patient. So I got the NCCT head done and seen the patient there first. So in this patient, there was no preceding history of any headache, fever, seizures, or any cardiac symptoms, or any rash, joint pains, weight loss, or a visit to the high altitude. He was posted at MH Merit only. There was no history of any drug intake or recurrent swellings of the leg. And as stated, he had no previous comorbidities. He had no similar illness episodes in the past. The family and personal history was non-contributory. So he had come to us with a sudden onset left-sided weakness with a left facial palsy, dysarthria, following a trivial trauma to the neck, and was brought to the casualty within 2 hours of the onset of the symptoms. So on examination, his pulse was 80 per minute, which was regular. Blood pressure was normal. Respiratory rate 18. The sugar document was 110. There was no carotid bruit, and there was no systemic features. On neurological examination, he was drowsy. GCS was E3, V5, and M6 with a left UMN 7th nerve palsy. He was able to answer questions. The power in the left side was 0/5. There was a partial gaze palsy. There was mild sensory loss, and other system examinations were normal. So he scored an NIHSS of around 14. So we got an NCCT head done. I do not have the images of the base hospital, so I'm showing the images of the Army Hospital when the CT angio and perfusion was done. So after getting the NCCT head done there, we could see that there was a just show that there was a dense MCA sign that was seen, and there was probably a right insular ribbon sign as well, and the M1 areas probably had hypodensity as compared to the left side, and the aspects was M1. The patient was thrombolized there with tenectase. His weight was 80 kg, so he was given 20 milligram of the bolus dose was given after Foley's catheterization and IV cannula placement and rechecking his blood pressure. He was shifted for CT angiography and perfusion, and post the thrombolysis, he was shifted to Army Hospital, the RNR, which is around 6 to 7 kilometers away. So when the CT angio was performed there, what was noticed was that as compared to the left ICA, there was focal narrowing of the right ICA. So possibility of a dissection of the right ICA, Peter segment was thought of. And in the MCA M1 segment, a complete cutoff was seen. Post this, the neurointerventionist was involved. The CT perfusion showed, however, we were seeing a dissection in the ICA territory, in the cervical ICA Peter segment. A mismatch was seen in the superior division of the MCA, and there was a significant perfusion mismatch that was noticed. Post this, the patient was shifted for mechanical thrombectomy and for DSA. And on DSA, a flame-shaped configuration of the dissection was noted on the base images. And post this, when the dye was shooted, the ICA was visualized only up to the most cranial part, the supraclinoid part. So a tandem occlusion was diagnosed in this case. So there was a cervical dissection and also a MCA occlusion that was found in this case. So the dissection flap was crossed with the guided catheter, and the cervical ICA, DSA had showed the occlusion to the supraclinoid, and complete M1 occlusion was found. And post this thromboaspiration that was done at 17:35 hours, it was found that there was done, and it showed a good recanalization post the thromboaspiration. Post that, for the proximal ICA dissection, the stent was placed, and after this, the complete right ICA, MCA, and ACA showed good angiographic results. So post this, the patient was shifted to the ICU, was kept on ventilators. He was started on high-dose statins. He was given anti-edema measures in the form of mannitol and was given prophylactic antiepileptics. Patient, however, became increasingly drowsy, although the pupils remained normal in size but showed sluggish response. And on the second day of the NCCT, he had a large area of hypotensity was seen in the MCA region, again in the superior division of the MCA region. So despite IVT and despite doing a mechanical thrombectomy, a large MCA superior division predominant occlusion was found, and the patient had to undergo a right frontotemporal decompressive cranectomy with a bone flap that was kept in the abdomen. Post-surgery, patient was given DVT prophylaxis in the form of LMWH at 0.4, 40 milligram OD subcutaneously, and Disprin was given 150 milligram via the trials tube. So post-operatively, the NCCT had showed improvement of the mass effect and the midline changes. Patient was kept on the ventilator, and subsequently tracheostomy was done, was managed for ventilator-associated pneumonia, and other causes for the young stroke were also worked up for the cardiac, vasculitic, and prothrombotic workup, and everything turned out to be negative. Patient eventually had a improving course. He was discharged in third week of illness. However, he was not doing well. He was discharged at an MRS4 state. He was tracheostomized and was discharged on dual antiplatelets. However, he showed improvement, and tracheostomy closure was done, and cranioplasty was done at second month after his signs of improvement. And at third month, he had a MRS of 2. I'll just show you. So he was able to walk on his own at third month, although he was not able to carry out all his activities on his own, but he was mobile on his own. So my discussion is going to be basically on dissections. So dissection, as we know, is a very common cause of stroke in the young individuals. It is said to be almost 20% of the stroke in young is related to dissections. And of these, the extracranial dissections is far much more frequent than the intracranial. And among the extracranial, it is the cervical petrous segment, like in our case. Most commonly, it is due to trauma, which is usually trivial. And the neurological sequelae secondary to these dissections can be either because of thromboembolism, hypoperfusion, or because of local symptoms occurring due to compression of the adjacent nerves or the feeding vessels. In our case, it was probably because of a thromboembolism, where the dissection, the thrombus had dislodged from the cervical area and occluded the MCA area. Regarding the, so what we did was we did thrombolyze with tenectase. In this case, considering a large vessel occlusion, initially we did not have dissection as our first point because the history of trauma was given at a later date when the other family members had when the other friend had come. So thrombolysis in cases of these arterial dissections is safe. It is effective. Mechanical thrombectomy and intra-arterial thrombolysis are also treatment options for these cases, but these are only available only at expert centers. Regarding the medical management, antithrombotic treatment in the form of antiplatelets or anticoagulants is warranted in these cases for extracranial. However, in intracranial, we usually do not prefer anticoagulants because of risk of SAH, because they do not have the tunica adventitia. Usually, the antithrombotic treatment is usually warranted after 24 hours after the thrombolytic therapy that we usually do in every case. Regarding the evidence, it is as per the guidelines only in extracranial dissections. IV alteplase is known to be as per the guidelines of the EHA. It is considered relatively safe. However, in intracranial, it is unknown. And we, in this case, had done with tenectase, and for that, there are no foolproof guidelines for use in dissections. Regarding for the patients for the medical management, as stated, usually antiplatelet or anticoagulant therapy is usually warranted for at least 3 to 6 months. And for patients who are having the dissections, who are having recurrent events, they would the role of stenting is not well established, but it is usually done. Regarding the role of endovascular therapy, it is, as stated, it is used to treat patients with the ischemic patients despite antithrombotic treatments, and these can be done in the form of angioplasty or stent placement or embolization with materials. In our case, we had done with stent placement. However, there are no randomized trials comparing the endovascular techniques versus medical therapies and the safety and durability of these methods. The other point that another point was that usually with dissections, they usually have good recovery in 70 to 85% cases, but in 10 to 25%, they are usually left with major disabling deficits, and death may occur in 5 to 10% cases with dissections. Another thing that I wanted to quote was the state criteria for the decompressive hemicranectomy. That is, in younger patients who are having malignant strokes, early decompression usually produces good results. So as per this criteria, the NHSS, if score of 1A the 1A score is more than 1 or GC is less than 8, NHSS of 15 or more in non-dominant hemisphere, in our case it was 14, or more than 20 in case of the dominant hemisphere, a time period of within 48 hours of last being known well in the age group of 18 to 60s, and in patients with large vessel strokes, that is either more than 50% of the MCA territory or infarct volume of diffusion, as per diffusion, more than 150 ml, and they have a reasonable life expectancy. So if the patient fulfills this criteria as per the state criteria, then the patient should be offered early decompressive hemicranectomy. So learning points, according to me, for this case was that tenectase in a cervical dissection, in our case, was not associated with any hemorrhagic complication and can be used in dissections as well. And mechanical decompression in a young patient should be offered early. Thank you.
Thank you, Dr. Barun. I think that's a very interesting case. So before we go into the discussions, a couple of points I'd like to ask you. One is, what is the time difference between the onset and the tenectase?
So it is I'll just show you, sir.
Alteplase. Sorry, he got Tenectase, right?
He got Tenectase, and so we gave Tenectase. So the patient came to us in ER at 13:30 hours, sir, and he was thrombolized at 13:55 hours at base hospital.
At the base hospital. So,
Yes.
sorry, what was the onset?
So the onset was at 11 o'clock. Patient reported
11 and 13:55.
at 13:30.
So that means,
and in 25 minutes we were able to thrombolize because we did just only an NCCT head there.
that's right. Okay, so and the NCCT head he brought it from base hospital. Based on that, you did the
Yes, sir. So
thrombectomy, right?
we did it.
Sorry,
Yes, sir.
okay. And now, so this is close to I think 3 hours almost.
Yes,
okay.
sir.
Then can you show us that CT once again?
So,
What is the transport time between Meerut and Delhi?
So from base hospital to army hospital, it is around 7 to 8 kilometers. So, but that was at the peak time. So it took almost, I think, 35, 40. It must have taken
35, 40.
35, 40.
Okay. Can you show us that CT once again?
So can you see the CT?
No. I think it's not visible here.
Okay, sir.
Can you share your slide once again?
Okay, sir. I'll just share it once again. Just a minute. Okay. So the sharing was gone. Okay. So.
Yes. Is it the only CT cart available?
Yes, sir. Sorry.
Do you have any cart at the upper level?
No, sir. I'm sorry. I do not have the cut at the above level.
Okay. I mean, as you were talking about the aspect score,
sir.
I think if you look at the right hemisphere, it's the lentiform,
sir.
the insula, the M1.
Sir.
These three are definitely down.
Okay.
I might or might not consider internal capsule, but these three places are definitely down. Okay. And we need another cut at the centrum semioval level to complete the aspect scoring. So yes. This aspect is 7 at least as per this CT. And if you look at the upper cut, it might be a little below. So my point was, this CT was done at the base hospital. And if your CT aspect is below 6, especially below 5, so. Then mechanical thrombectomy does not give you much benefit.
So, right.
Second point was, patients particularly, I am keen to have more information on the collaterals. I believe the patient didn't have much collateral. Within this 3.5 hour time, or 3 hour time, he already had an aspect of 7 or 6 or somewhere like that. So definitely his collaterals are not helping him.
Yes, sir.
I think the reason behind this outcome of a full-blown infarct despite a recanalization is because of he already infarcted his brain before you actually open the artery. So if your aspect scoring is around 6, then probably it's and a poor collateral is not a good candidate for mechanical thrombectomy. So your TPA decision was definitely correct, but mechanical thrombectomy you definitely acted, but did not give you that benefit. So, probably that is the reason.
Right, sir. True.
Okay, sir. Asukan sir, any comments on this?
ठीक तुम उनसे बोल दो कि वो मुझसे बात कर ले.
Hello, Dr. Ashokan sir.
Can you hear me?
Yes, sir.
Can you
Yes,
hear
sir.
me?
Yes, sir.
So if you look at the CT shows a dense MCS sign, which the infarct or the insular cortex, etc. But history, this injury to the neck, that definitely says corrected dissection. First possibility, corrected dissection with the thrombus formation at the site of dissection, and maybe with a little pseudoaneurysm and embolus to the MCA, causing dense MCA sign. Of course, what you have done is correct. Tenectase, we have to try no other alternate, give that. You are given and you are taken up for angio. Angio shows definitely near total occlusion of the carotid artery. Near total occlusion, flame shaped. Thing is, now you are left with no other choice except with mechanical thrombectomy. You have done that and you could recanalize the vessel. But only thing, reperfusion you could not achieve because as Dr. Rai told already, infarction had set in, large infarct had set in. Definitely. But in this situation, what you have done, I think it's correct only. Having seen the total occlusion of the internal carotid artery and you tried recanalization. But the following day deteriorated. Another reason, maybe re-occlusion of the stent itself. I don't know. So probably would have gone for a balloon angioplasty and this tenectase, etc. Then later would have planned for stenting. The stent re-occlusion or stent occlusion would have been the problem. And another thing, as already infarcted brain, this swollen up with edema and deteriorated. And young individual, next third thing is no other choice except for decompression craniectomy. That's what you have done and the patient improved. So I thought two things in this case. One is stent occlusion, number one. Number two, already large infarcted brain and could not vascularize. Even though recanalized, could not recanalize. That's why the patient could not get out of it and had to end up with the craniectomy and later improved well. That's my take. Thank you.
Thank you, sir.
Sir, Professor Mishra, sir.
You're muted, sir. Sir, you're muted.
Sorry. Yeah. Is it okay? Yeah, I agree. There may be a possibility of either total occlusion or a stent or pre-occlusion resulting in total infarction. And after hemianectomy also, the patient does show significant improvement. Maybe what you show is a fairly good, I was not expecting that good a response. And that's very, very interesting. I think very interesting case. Thank you very much.
Thank you, sir.
Thank you. So I think otherwise, whatever points you have discussed about dissections, I think this is exactly what anybody would have done in this situation. So, and of course, tandem occlusions with the dissected neck artery, you might need angioplasty or stent to make room. So it's sometimes going through the true lumen and passing the guiding catheter upstairs. It's sometimes challenging, but yes, we have done it. So, I think this is another very interesting case and very efficiently managed. So thank you very much.
Thank you, sir.
So Dr. Neha.
Yes, sir. Thank you, sir. When I spoke to Dr. Varun a few days ago, he told me that his case is, thrombolysis in a young soldier. It didn't occur to me that he is from a, army hospital until I read through your CV and found out. So for the first time ever, we have had somebody from the army, hospital, and we have had a case in a person with this background, somebody who's a soldier. So respect for you, respect for your work. Thank you so much for bringing this case forward. A very young gentleman, very well managed. And thank you, dear doctors, professors, Dr. Mishra sir, Dr. Jayanta Roy sir, Dr. Ashokan sir. Once again, thank you very much for sparing your valuable time. And as people say that we don't say bye, we say until we meet next. So I would again say that until we meet next month with again exciting cases. Till then, we wish all of you stay safe and stay healthy. We'll meet next month again with exciting cases. Good night, everyone. Thank you so much.